Hello, everyone, and thank you for joining us for Echo Asthma Bootcamp. My name is Ashley. I'm your facilitator. I'm joined today by my coordinators, Rachel and Tabitha, and our wonderful hub team, Dr. Mandeep Jassal, Dr. Christian Hermanson, and Andrea Jensen, certified asthma educator. Hi, Dr. Nietzsche. How are you? Nice to see you. All right. Now, as I said, this is a slightly longer video, so do keep that in mind, but we go into great detail. Dr. Kerr goes into great detail for you. So without further ado, let's talk about biologic treatment options for severe asthma.
So welcome everybody to today's Echo Asthma program, session 4 on biologic treatment options for severe asthma. My name is Dr. Sucharita Kerr. I'm an assistant professor at Tufts University School of Medicine and an adult pulmonologist at Tufts Medical Center. And I look forward to spending the next hour with you talking about some of the exciting biologic treatment options we've had in severe asthma. So starting with the Gina Guidelines, we've reviewed these before. Gina Guidelines do not necessarily specify which exact drug to use, but really provide us with guideline to help selection of a treatment for a particular individual patient. And that really depends on the patient's own disease characteristics, their preferences, what phenotype of asthma they may have, what their functional ability is to perhaps use a medication, and then to overall consider the complexity of the medical regimen. The biologics in asthma are among the step 5, the rightmost on the Gina guideline. So there are 5 approved biologics currently in the United States. Omalizumab, which is an anti-IgE monoclonal antibody, is the oldest. We've had about 18 years of experience with this drug. Mypolyzymab was then approved many years later and is an anti-IL-5 monoclonal antibody. Restless-Map, which is an IV formulation, again an anti-IL-5 treatment option. Benralizimab is an anti-IL-5 but really works against the receptor rather than the IL-5 molecule itself. And then the most recent kid on the block is Depilomab, which works against the anti-alpha subunit of interleukin-4 receptor. The most important thing about these drugs is that while they do significantly improve exacerbations or decrease exacerbations, improve lung function, and reduce the amount of oral corticosteroids that a patient is exposed to, it's really important to remember that these are add-on treatments. That means that it is only used for patients who have uncontrolled asthma despite the regular use of a combination of medium to high dose inhaled glucocorticoid and a long-acting bronchodilator, and people who have impaired lung function. So it's really for those patients who cannot be maintained despite step 4 Gina guidelines. A little bit more about these approved biologics. All except for Restless-Map are subcutaneous by route. Restless-Map is the only one that's IV. Some of these, Omalizumab and Mypolyzymab particularly, are also approved for ages over 6. So for a pediatric population, this table highlights what the patient selection is, and we'll talk a little bit more about each of these drugs in detail and what the evidence is behind using these drugs. And then I really want to use this table to highlight some of the adverse effects. So for Omalizumab, which is an anti-IgE treatment, anaphylaxis is about 0.2% of patients. While the risk is really low, it is recommended that the patient carry and know how to use an epinephrine injection with them at all times. The risk of this anaphylaxis is highest initially when they initially get the drug, but certainly has been reported up to 7 days out. Patients also complain sometimes of local reaction at the injection site. For Mypolyzymab, in some of the studies, patients have had zoster. It's rare, again, less than 1%. And the guidelines typically say to consider a vaccine against zoster if medically appropriate. It's important to note that some of these vaccines are live, and so if the patient is at risk for disseminated zoster, for example, if they're on high-dose steroids or on immunosuppression, it may not necessarily be feasible to give them a shingles vaccine. Headaches are quite common, but can be dealt with some Tylenol, and local reaction can be a possibility as well. For Restless-Map, interestingly, one of the side effects is oropharyngeal pain. Anaphylaxis has also been described. Again, it's 0.3%, so it's a low risk. however, is a real risk and is associated with a boxed warning for the drug. For Benralizimab, this is indicated predominantly, again, for eosinophilic asthma, and some of the side effects include headache, pharyngitis, and a hypersensitivity reaction. And for Depilomab, finally, injection site reactions are common in about 15%. Hypersensitivity can be noted, and this can present as urticaria, other rashes, evidence of serum sickness. Paradoxically, these patients can also have eosinophilia, and it has been attributed in about 4% of patients who receive Depilomab, as well as the presence of some vasculitis. Ocular symptoms should be looked for when patient is on Depilomab, as these patients can often develop conjunctivitis or keratitis. And I'd like to highlight that for all of these drugs, because it's meant to be an anti-eosinophilic inflammatory drug, it's really important to take a detailed helminth infection exposure history, particularly about travel or if they've ever had a helminth infection in the past. And it's important to treat that helminth infection before starting any of these drugs. So let's go through each of these drugs individually. So Umalizumab was approved back in 2003. So as you know, we have many years of data and really good data to support this drug. It has been used for patients who have moderate to severe asthma with a positive skin allergy test, and those who've been poorly controlled otherwise on an inhaled corticosteroid. The dosing for the drug really depends on what the patient's weight is, as well as what the IgE level is and the age. Typically, though, depending on these levels, a dose comes to somewhere between every 2 to 4 weeks. It's a subcutaneous injection. And the data really supports the use of the drug. Cochrane analysis a few years ago of 25 studies showed that it significantly reduced the exacerbation. And overall, there was an absolute reduction in exacerbation compared to placebo, where it was 26%, down to Omalizumab, where it was 16% exacerbations. It also has shown to reduce the risk of hospitalization, the significant absolute reduction in the risk, as well as a decrease in the risk in the utilization of inhaled corticosteroids, but not necessarily oral corticosteroids. Overall, in this Cochrane analysis, it was shown that Omalizumab was associated with less adverse reaction compared to placebo, except for the local injection site reactions, which were higher, about 9% in Omalizumab compared to 5% in placebo. Again, there is a risk of anaphylaxis. People have to carry the epinephrine injection with them, and it's up to us as healthcare providers and nurses to educate the patient about the use of it and the need to carry it with them, particularly around the time that they're getting the injection. The next is Mypolyzymab. This was approved by the FDA in 2015 as an add-on therapy for severe asthma in kids 6 and over with an eosinophilic phenotype. Of note, an auto-injector is available for this drug. However, it's approved for ages 12 and above. It's a standard dose of 100 milligrams administered subcutaneously every 4 weeks. And there are really 3 pivotal studies that led to the approval by the FDA. First is the DREAM study that enrolled over 600 patients with severe asthma and tested 3 different doses, 75, 250, and 750 milligrams. And this study really showed that Mypolyzymab cut down exacerbations by 50% at all doses with an excellent safety profile. The MENSA study following the DREAM study recruited 576 severe asthma patients, gave them both IV as well as a subcutaneous dose and compared that to placebo. And both IV and subcutaneous cut down the exacerbations by 50%. Not only this, it also showed improved lung function as measured by FEV1 and improved ACQ scores or symptoms of asthma. And then finally, a study of 135 patients published in the New England Journal of Medicine that recruited patients with severe asthma showed that Mypolyzymab cut down oral corticosteroid dose by 50%, 32% decrease in exacerbations, as well as a better ACQ score. The next is Reslizumab. This is an anti-IL-5 drug approved by the FDA in 2016. It's an add-on therapy for patients with severe asthma, mainly for adults 18 and over with an eosinophil phenotype. Because it's an IV drug, it takes a little bit longer to administer, and it's given by an infusion every 4 weeks with the dose of 3 milligrams per kg over 20 to 50 minutes. There is a 0.3% risk of anaphylaxis with this drug. And there are 3, again, pivotal studies that I'd like to highlight here. The first one is 2 randomized controlled trials that recruited about 953 patients with severe asthma or with eosinophils over 400. This study showed that Restlizumab cut down exacerbations by over 50%, and they had similar worsening of asthma symptoms in both Restlizumab and the placebo group. A randomized controlled trial that recruited 325 severe asthma patients compared two different doses, and this study showed that the lung function is measured by FEV1 as well as symptom questionnaires is measured by ACQ, and the AQLQ did better in the drug or the Restlizumab group compared to the placebo group, and that the higher dose, the 3 milligram per kilogram dose, did better than the lower dose. And finally, a third randomized controlled trial in chest back in 2016 recruited about 490 patients with a 4:1 randomized design, used the dose 3 milligrams per kg. And it's interesting to note that the positive effects, the benefits of Restlizumab in this population was seen only for people who had an eosinophil count over 400. And hence, that's when we consider using this drug, is when people have eosinophil counts over 400. Particularly important to note that in this study, that folks who had EOS below 400 did not benefit as much. The fourth drug is Benralizimab. This is an anti-IL-5 receptor antagonist approved more recently in 2017 for ages 12 and above with severe asthma with eosinophilic phenotype. The dose, again, is a standard dose, 30 milligrams subcutaneously. The important thing here to note is that for the first 3 doses, it's administered every 4 weeks, and then thereafter, there's flexibility to administer it every 8 weeks. There is also an option for self-injection here with a pre-filled auto-injector that was more recently approved in 2019. And again, the pivotal studies that showed, the first one was a randomized trial that showed that Benralizimab cut down annual exacerbations rates significantly in these patients. This study looked at every 4-week administration as well as every 8-week administration, and both did better compared to the placebo. In addition, lung function was better as measured by FEV1 as well as the symptom score. Long-term data from the above study and aggregate data of over 1,100 patients showed that 75% of these patients had a decrease in more than 50% dose of oral corticosteroids after about 84 weeks of treatment, and 39% of patients identified a more than 90% decrease in the steroid use. So it really helps cutting down steroid use and exacerbations in these patients, in addition to improving lung function and symptoms. And the most recent drug is Depilomab. It was approved in 2018 for ages 12 and above for patients with severe asthma. It's an anti-IL-4 receptor alpha monoclonal antibody that further blocks the downward signaling both of interleukin-4 and interleukin-13. It's approved for 2 different doses. We also have some long-term data for this because it has previously been approved for another indication for atopic dermatitis, and more recently for asthma. Both doses are self-administered, they're subcutaneous administered. The first dose is 400 milligrams for the first dose, followed by 200 milligrams every 2 weeks. And then if the patient has oral corticosteroid dependent asthma, then it's recommended that a higher dose be used. This is 600 milligrams for the first dose and then 300 milligrams every 2 weeks thereafter. Home administration is possible. And there are pivotal studies that show that it cuts down exacerbations by 47% in patients who were treated every 2 weeks, associated with improved lung function. And another study of 200 patients showed that it cut down the dose of oral corticosteroids by 70% in the drug group or the Depilomab group compared to only about 42% in the placebo group. And 80% of Depilomab patients had at least a 50% steroid dose reduction and a 59% lower exacerbation in the Depilomab group. So really tremendous amount of data with all of these drugs. Now, while there are 5 approved drugs by the FDA for patients with severe asthma, I'd like to mention at least one, Depilomab, which is currently in development, and these are the results of the phase 2 trial that came out a couple of years ago in the New England Journal of Medicine. Depilomab is an antibody that is directed against the thymic stromal lymphopoietin, or TSLP, which, if you remember, is pretty upstream on that graph that we discussed last time in the inflammatory pathway. And this study is called the Pathways Trial. It's a phase 2 randomized double-blind placebo-controlled trial of Depilomab in patients with a poorly controlled moderate to severe asthma despite medium to high doses of inhaled steroids. And they recruited over 580 patients that were randomized to either placebo, which are the gray bars, or the colored bars, which are different doses of Depilomab. And what you could see is that there was significant reduction in the annualized rate of asthma exacerbation in the 3 doses compared to placebo. Most of these p-values are just statistically significant with the exception of a couple. I think the most important take home from this, although it's a phase 2 study, the importance here is that the drug decreased severe asthma exacerbations independent of their type 2 status. So one thing to highlight is all the 5 drugs that we have so far that are FDA approved have been approved for type 2 asthma. We do not have any FDA approved drug for non-type 2 asthma. So this is really exciting that this drug has potential for helping our patients who have non-type 2 asthma, who really don't have much with the exception of our standard inhalers at this current time. And it's one of the reasons that the drug was fast-tracked by the FDA in 2019, and more to come about this in the future. I'd like to also briefly mention the role of bronchial thermoplastic. This is rarely done, but I think it's important for us to talk about it. It involves 3 bronchoscopic sessions that leads to radiofrequency ablation or heat wave application to the airway smooth muscle. As you know, the smooth muscle in asthma plays a very important role in bronchoconstriction. And so this applies radiofrequency ablation to the smooth muscle in the airway. The effects have been studied in the short term, unfortunately, because of the bronchoscopy and the airway irritation, it actually leads to increase in asthma exacerbations. There was also a large placebo effect noted in these clinical studies. Long term, however, it has been shown to reduce exacerbations as well as improve symptoms in the following year. There's no clear evidence, however, to guide patient selection as to who's going to benefit, who's not going to benefit. And so the current utilization is really restricted to clinical trials or registry uses. So I'd be really amiss if I didn't talk about COVID-19 and what to do with these biologics in our current pandemic climate. There is a paper that was recently published where a group of experts across the world really got together to discuss what to do with patients who are already on biologics in the pandemic or if they get COVID-19 infection. And so these are some of the highlights from that paper. Again, I have to preface this by saying there's not a lot of data to support it, but these seems to be reasonable conclusions. First, in the absence of data that would indicate any potential harm, continuing the administration of biologics during a pandemic in patients in whom such treatment is clearly indicated and has been effective. Second, in prior studies, no risk of increased infection susceptibility or immune suppression effect has been reported to date. In fact, Umalizumab had a possible anti-infectious effect, and hence they recommend no need to discontinue the drugs during a pandemic. And until more information is available, patients with severe asthma plus comorbidities infected with the SARS-CoV-2, decision for maintaining or postponing biologics until patient recovers should really be done on a case-by-case basis, supported by a multidisciplinary team. Our experience here in my institution is that we've continued people on biologics and they've done well. Some patients, we've actually transitioned them to home administration to avoid having them come in to the institution for shots, particularly for the need of physical and social distancing and avoiding exposures. Particularly for Omalizumab, there has been some provision that has been provided for the pandemic to allow a self-administration at home with certain guidelines in place that we can discuss at a later session. So I'd like to finish up by talking about some of the guidelines for referral to an asthma specialist. These, in my mind, include patients who've had a life-threatening asthma exacerbation, such as those who've been in the intensive care unit, potentially intubated for their asthma, patients who, despite appropriate treatment, have not met their goals, patients with atypical presentations who we question the diagnosis of asthma, patients with particular comorbidities such as ABPA or allergic bronchopulmonary aspergillosis or eosinophilic granulomatosis with polyangiitis, patients who you're potentially considering biologic treatment, patients who require consistently step 4 or higher treatment according to the Gina Guidelines, patients who require 2 or more corticosteroids in 1 year, as well as folks who require hospitalizations for exacerbations. Thank you for listening and for your attention, and we'll open this up for Q&A.
All right, thank you, everyone. Thank you, Dr. Kerr. All right, let's open this up to Dr. Jassel for his key takeaways.
There was a lot to digest in that presentation, but I'm going to try to hit on the key points from a pediatric standpoint. So of the biologics she's discussing, if we're going to talk about pediatrics, we can eliminate Restlizumab from the conversation because it is FDA approved for those 18 and up. So I don't even put it as part of my treatment regimen for most of my kids. So the ones I want you to think about are Xolair and Mypolyzymab, which are approved for those 6 years and up. So if you look at it from a timeline of an individual, you can group Xolair and Omalizumab and Mypolyzymab together. You get to 12 years of age, not only do you get those other 2 biologics we just discussed, but now you have the option of using Benralizimab or Fasenra, and you also have the option of Depilomab or Depexin. So now we have those that we could use from 12 until 18 years of age and up. So that's the landscape that we have available. But one of the more important things that she said is that it is an add-on form of therapy. In other words, you add it to a regimen that isn't working for you. And going to our final slide and trying to tie it to our first slide, it's about referral or thinking of biologics during the time point of referral in terms of saying, I'm on a high dose form of inhaled corticosteroid, and you're on at least 2 controller medications, which if you think about it, a lot of us providers are taking care of patients who already meet that criteria, that we keep and maintain them on these regimens, yet we know that they're not well controlled, be it either because of poor compliance or continued need for steroids or hospitalizations. But just so you understand, once you meet that criteria, you probably can consider biologics at that point. It should be part of the patient-provider discussions. Now, the other thing, and we're going to talk about this more next week in a little bit more detail, but when she was discussing concerns about side effects, the one that, from a pediatric standpoint, we use quite a bit because it's the oldest one out there, and we tend to be a bit more conservative in pediatrics, is that of Omalizumab or Xolair. And we were made aware just last week that Omalizumab is now approved as a self-injection option. So now there is all options. So in turn, all pediatric options now can be given in the home setting, which is really great for families. So now they'll have a full complement of options that really the adults had the luxury of having, and now we have the luxury of having too in the pediatric population. She did mention about the concern for parasites. I would be thoughtful of that. I usually start to screen for that only in 2 situations, but one more in particular, if there's a history of international travel in a recent time frame. So if I do hear that, I will screen for helminthic infections. But in general, I don't get overly concerned, but I do screen for that if there's any history at all. And then when she went through all of her slides to say this drug resulted in this reaction in this trial, I want you to kind of boil it down into 3 categories. So the first category is, here's your first class, and that is you're an anti-IgE, or you're targeting allergic asthma. If that's what you're targeting, Xolair is your drug. And if Xolair is your drug, just get a total IgE level along with a perennial arrow allergen screen, whatever you prefer for that, dust, dog, cat, dander. There's a panel of that. And there's other labs you should order as well too, but those are the 2 big ones. Then you go to the second class, which are IL-5 agents. And now for IL-5 agents, we have Mypolyzymab or Nucala. And for that, you want to know what your eosinophil count is. Now, usually there's a cutoff of around 150. I prefer 300 absolute eosinophils per cubic millimeter. But you can, I like higher amounts because usually I get a better response, but that's the first type of that. And then there's a second one which works at the receptor called Fasenra. So Fasenra has a different dosing regimen too. So you got to talk to the patients to figure out what works for them. Sometimes they don't mind getting the shot every month. Other times it's a struggle that they say, I only want to see it every 3 months because I can't see my child get the shot every month. I can't give it to them every month. And then you have the third class, which is the IL-4, IL-13, things that block those receptors, and that's Dupixent. So it's nice. You get two things with one shot. And the nice thing about Dupixent is it can be used to treat eczema. So if you have a child with really severe atopic dermatitis, moderate to severe atopic dermatitis, that is resulting in them scratching so much that they're causing their skin to bleed, and you got bad asthma, that's a reasonable option to consider if you're 12 years of age and greater. But the one thing I want you to get from all those slides, from slide after slide after slide, I think you guys noticed that most of those biologics reduced asthma exacerbations by half. So then you have the question is, which one do you use? And that's still a matter of debate. And so that's really a bigger question for asthma specialists as a whole. But most reduce exacerbations by half. So when you're referring or you're talking about it with your patients, you can kind of talk about it in those realms. Some do a little bit better, some do a little bit worse, but it's around there. And then not to overwhelm, because I know that we've been talking a lot about that stuff, but I wanted to talk about that biologics and COVID-19. So obviously, COVID-19 is not going anywhere anytime soon, unfortunately. But the key way that I talk about asthma management and COVID-19 is the way I treat COVID-19 in an asthmatic is controlling the asthma. That's how we manage this disease process in asthma. And if biologics are your means to get you under control, then that's what we're going to use. I started quite a few patients on biologics during this COVID-19 period. And I think it's really important to remember whatever it takes to get them under good control helps them if indeed they do end up contracting COVID-19 during this time frame. And I think those are the major takeaways I wanted you to get from this.
Yeah, I was impressed with the quality data, the quality of life data that was part of that as well. I wonder if they can redo those types of studies now that all of them can be used now at home. So there's less of the issue of, oh gosh, I got to go to the office again and get that shot. If they have that ability to do it at home, that may help with people's quality of life scores. It almost feels a little bit like a class effect in the sense that a lot of them had the reductions in FEV1 or exacerbations and that kind of thing. You're reducing steroids, although I think Dr. Jassel was great in explaining the differences between what they hit and when you choose one or the other. I think in family practice, I might be more likely to use the one that I can get approved, which may influence which one I decide, choose, is what the insurance company will let me do.
Hey, I just put a little link in the chat for everyone just about the update with the Xolair being able to be self-administered now, but there are some precautions there. For instance, they have to be observed giving their injection for the first 3 months. They also have to be trained into recognizing the signs and symptoms of anaphylaxis and know how to treat that. And, with any medication, it's not right for everyone. So I know we'll talk about this. I think it's on our next session about shared decision-making, but something that patients and doctors can talk about together. And for what it's worth, I really feel that biologics are lifesavers. My husband, which kid? My middle kid, he was in the hospital 7 times and 2 ICUs before he started on Xolair, and really literally saved his life. It was back in the day when it wasn't available until kids were 12. So we had to wait until he was 12, and he was on it up until he left for college. Stayed on all of his controllers, and he's still to this day is still on all of his controllers. But, there are those patients that no matter what you do, even making the home allergy and asthma friendly and taking in all the environmental components as well as compliance, as well as inhaler technique and all of those, they just still can't be controlled. So biologics are, yes, they're expensive, but they're worth their weight in gold.
Looks like we have a question from Lisa in the chat. I don't know if you addressed this already. Approved for self-administration, is it 12 and up?
I haven't seen any age limitations, and it's my first time getting familiar with this. Lisa, actually, Andrea was the first person who brought it to my attention on the Tuesday after the previous week when it was finally approved. So I'm actually going to find out, because I think it's for 6 and up. I did not see any limitation, but we can confirm it.
Great.
And to be honest with you, Lisa, actually today, this afternoon, I'm having a discussion with my nurse to get my first patient converted over on the self-injection option, because I think for this family in particular, to pay for parking twice a month is really getting quite burdensome for them. So I'm really excited that if I can pull this off.
Is the company offering anything like some of the other companies offer, with training, having nurses go to the home and train the patients also? So you do an in-office training, and then I think it was, which one? I think it was the Dupixent. We could call the company and set up a home nurse, correct?
So I've heard, so I know that for Dupixent,
at least in our area, where that's what we've been able to do.
Yeah, I know for our area, Dupixent, that's possible too. Now for Xolair, I'm not sure, because I just, this is fresh off the presses kind of stuff. But for me, I'm sort of spoiled, mainly because I have a specialty pharmacy affiliated with Johns Hopkins. So we have Johns Hopkins Specialty Pharmacy pharmacists who actually make arrangements. So when I send the drug, the prescription to our specialty pharmacy, our pharmacy has pharmacists that either, well, they used to go in the home setting. Now we're starting to do that again. But during COVID, we would do it through telemedicine, and they would watch, observe, teach, and we would do everything for at least 3 involved visits. Then after that, the patients can speak to our pharmacists if they have any questions.
That's fabulous. I'm jealous.
I know, I'm spoiled.
Dr. Dupree, I saw that you had your hand up. Do you still have a question?
I'm not quite sure why that's under doctor. I should be respiratory, but yes, you guys were going through the sessions and you said that there's several types of asthma. And I guess I don't understand what type 2 asthma is.
That's a really good point. We should always keep emphasizing it, because when we're talking about severe asthma, differentiating it between type 1 or type 2. So type 2, and when we were talking about the endotype, or the disease mechanism that kind of drives severe refractory asthma, that the type 2, for example, is that driven largely in an eosinophilic or an allergic-like pathway. So our currently approved biologics, so the topic of this module, is directed at that kind of eosinophilic or allergic-like asthma. So if you have that, which most children do, or most in the pediatric population do, that's going to help treat severe asthma driven by that specific mechanism of eosinophilic or allergic, which we can monitor through laboratory work. Then you have type 1, which we don't see as much of, but we definitely do see some of it in the pediatric population, where it can be more neutrophilic, or it could even be a little bit of a combination of both, neutrophilic and a little bit of eosinophilic asthma. That gets harder to treat because our currently available biologics, like we mentioned in terms of those classes, they don't really work for those specific type 1 disease mechanism-based asthma. So when Dr. Kerr briefly talked about that really important drug that we keep hearing so much about, and it's probably going to be a very big drug when it officially is approved by the FDA, that was Depilomab. And when that gets approved, that will be a very big one, because that's our only biologic that we could potentially use for type 1 asthma.
Thank you, Winnie. Dr. Nietzsche, did you have a question?
Yes, in Germany, we have this option of self-injection already maybe 1 year. But we noticed that a lot of patients don't want to do it at home. And they even don't want to do it at other doctor's house. Because of these thick needles, keep on to the person who started it, usually.
Yeah, I think you bring up a really good point. I think you actually bring up two good points. You're, like always, you guys are always ahead of the curve. You guys approved it earlier. I know that that you guys were using these options much earlier in terms of the self-injection option in the home earlier than us. And it took the COVID pandemic for us to start pushing in that direction. It is going to be a very interesting discussion. I have found too that a lot of families do get scared with the injection option. Unfortunately, we talked about this earlier with the Xolair needle being a little bit different than the pens that can be used, the self-injection pens for Nucala or Fasenra, for example. Those are much easier on patients. They prefer those. And this Xolair is going to be a very interesting option. So one thing that we are going to be monitoring, this is what I plan on doing with my own patients when we tried it, when we're going to show the parents how to give it, and they're going to show us how they give it. I'm going to rely on my pharmacist. We're going to see what their comfort is about giving this, because if they don't have that comfort, we are not here to push anything they don't feel comfortable doing. We'll just continue office-based injections, because you are right. And we're going to talk about it more next week, but there are some parents that are just absolutely frightened on giving shots to their children.
Thank you, Dr. Aslo. Winnie has another question.
The one that's being developed now, the new one, what age is that approved for? I may have missed that in the slide. Sorry.
No, it's only being tested in the adult population. I don't know of any. It's in phase 3B testing. So it's not even in phase 4 testing, at least to the best of my knowledge. I know the phase 3B analyses are ongoing, but I don't know, and it's not approved, or it's not, to the best of my knowledge, not being tested in any major pediatric oriented trial, at least one that I'm familiar with.
Dr. Jassel, I just found another news release, and it's talking about the ages here. And it says, use Xolair as prescribed for children 12, and I'll put the link in there. For children 12 ages and older, Xolair may be self-injected under adult supervision. For children 6 to 11 years of age, Xolair pre-filled syringe should be injected by a caregiver.
I had a feeling, yeah.
So I'll put that in the chat.
Thank you.
Thanks, Andrea.
Yeah.
Oh, and for Winnie, I'm sorry, I just had to quickly go on to clinicaltrials.gov. I just wanted to see if there was some trial I didn't know about. There is an extension trial being done by AstraZeneca for children. It looks like they're trying to enroll children 13 and up. So we'll see how many children they get. So normally that's the usual path, I suppose, 18 and up, then 13 and up, and then eventually it'll keep getting down lower and lower. But I would look at it in the adult population mostly.
And you said that's in the phase 2 trial now?
Phase 3B.
Phase 3B. Okay, thank you.
Sure.
All right. Thank you, Dr. Jassel. Thank you, everyone, for your wonderful input. I think in the interest of time, we will get on to our patient case presentation by Lisa today. I am thrilled. Thank you so much, Lisa, for turning this into us, for filling out this form. I'm going to share my screen now for everyone to see. I think that's big enough. And Lisa, you just let me know if I'm not scrolling fast enough, okay?
Great. I'm actually going to try and just my screen because it's a little easier. So as I'm reading along, maybe you'll be able to see. So I got this form late last night, and I've known this patient, since 2013 or 14. And you can see that his year of birth is 2012. He's a male, a white male child born in the United States. And we met him during his ICU admission. And it was quite an overwhelming experience to meet this, small child. At the time, he was intubated and he was only 16 months of age. So we had a lot of work to do to try and find what were all the risk factors that caused this. So I'm just going to go a little bit over his birth history. He was full-term C-section. He did spend some time, about a week in the NICU for meconium aspiration, but no intubation and no issues post-birth. He was wheezing at about 1 year of age, but we have a very vague history on what that type of wheezing was. Was it with a respiratory infection? He is known to have viral triggers, and he's throughout his life have had multiple viruses detected by viral culture during hospitalizations. And you'll see when I get further on, you'll see how many hospitalizations we're talking about. But it's been throughout the panel of the respiratory panel viruses, he's had all of them that induce an asthma exacerbation. So his main symptoms are with respiratory infections, causes wheezing, shortness of breath, and coughing. So what we have here is a history of a 6-year-old, well, now he's an 8-year-old boy with persistent asthma, seasonal allergic rhinitis, and multiple food allergies, severe eczema. He's got a history of poorly controlled asthma with risk factors of multiple courses of steroids in the past. His comorbid conditions are atopic dermatitis, as I said, with severe eczema and multiple food allergies, allergic rhinitis. So he's also diagnosed with reflux and eosinophilic esophagitis. He does have smoke exposure in the home, and psychosocial issues really impede on our ability to care for this child and for him to have an improved quality of life with therapies. They have been homeless for a number of years. The treatment adherence issues and the psychosocial issues of this family play a huge role in the care that we can offer. We have a complex medical team with him: pediatric pulmonary, allergy, GI, dermatology, sleep medicine, genetics, ENT, endocrine, his primary care provider, just to name a few. Nutrition has been involved with this patient, social work, our case managers. We have developmental psychiatrists and psychologists that we've tried to refer them to and haven't been successful yet. We utilize the home care nurses, school nurses, and community health workers, including child protective services. So we really do have quite a comprehensive team that we try to utilize on a regular basis with them. Let's see here. Under his asthma symptoms, as I said before, yes, he does have coughing. He has expiratory wheezing, inspiratory wheezing on occasion, but not usually. It's usually very expiratory wheezing based. Shortness of breath is something he complains about with chest discomfort. He does develop work of breathing quite quickly when he has an exacerbation. Responsive to his bronchodilators, yes, he does have a nice response to his bronchodilator therapy, and he does respond to systemic steroids. His triggers are upper respiratory infections or viral illnesses. Outdoor allergens, although his immunocap allergy testing has not really identified much in the way of pollen allergy, he does have outdoor sneezing, runny nose, and more coughing when he's playing outdoors more. Indoor allergens, he has been tested positive to cat and dog animal dander, and as well as cockroach. Exercise, I'm sorry I didn't click that one off. That's a big one for him, especially if the exercise, I wrote it down at the bottom here, is outdoors. So, if he gets excited playing on the playground with his friends at school, the mom will get a phone call from the nurse that he's having some difficulty and she needs to come and pick him up. Some of the medications that have been used and which we're currently using, I'll go through the current. Right now he's on Dulera, and he does use that with a spacer. He's on Spiriva, and if I believe, yes, the physicians, if I'm thinking about this correctly, they do use that. They have used the other type of, not the Spiriva Restless Map, but they've used it with a spacer before, trying to get improved deposition for him. He was considered for Xolair therapy. So when we're looking at the biologics for him, at the time we were looking at biologics was just when he hit around 6 years of age. And you'll see when you look at his list of hospitalizations, that's when he was hospitalized the most, around 2018 and 2019. And he was on multiple courses of oral steroids, which were affecting his growth and his behavior and putting him at risk. So we considered Xolair. However, when you see his labs, you're going to see that his total IgE level was greater than 35,000. And so our physicians, the allergists and the pulmonologists got in touch, with the company, and they discussed it with their medical directors, and there was no indication that anyone could find or use for the patient with this high of an IgE, and also the risk factor for him to possibly have an anaphylactic reaction. They were very concerned about that because he does have severe food allergies with risk for anaphylaxis. So they did not move forward on Xolair because of that. In 2020, when Nucala was approved for 6 and up, we were able to start Nucala therapy. Unfortunately for us and him, this was just around the time of COVID starting, and we were only able to get a couple of doses into him. We did it in a very protected area in the hospital, in our pediatric infusion room under direct supervision, just because of, again, his risk for anaphylaxis, even though that wasn't as big of a concern with Nucala. And we did meet the criteria with his eosinophil count, which will look at his labs. But because of the risk for COVID, the parents were too afraid to bring him into the hospital, into an office to continue the therapy, and they stopped it as of last April. And we haven't been able to get them back on board with that. We're currently in discussion with his dermatologist, because the Dupixent was approved for 6 and up now. And so because he has severe atopic dermatitis, they're considering to add that therapy onto their regimen plan. They're in discussion with the family, and we're hoping to see benefit with his asthma from that. He was on Singulair therapy, but it was discontinued because he is having such behavioral problems, and he's having sleep issues. He was having nightmares. And although this is a very confusing mixed bag because of other medications he's been on, such as systemic steroids, it's hard to tease out which one is causing the side effects for him. But when he truly was just on the Singulair and not on the oral steroids, he was still having behavioral problems. So it was recommended that medication stop. So that was discontinued. He uses his allergy regimen, which includes Flonase to clear his upper airway, and Zyrtec to control some of his environmental allergies. He also, in 2019, when we didn't have a lot of things to offer in our toolkit for him, one of the add-on therapies, going by step therapy of the EPR guidelines, was we added Theophylline for this boy, which is not something that we do, especially in children, because of the risk for side effects. But they did try this. However, he can't swallow pills, and he can only take liquid, and you can imagine the volume of liquid he had to swallow and how many multiple times a day to try to get Theophylline and even try to get a therapeutic range, which we really didn't get. He was spitting up and vomiting it and choking on it, and it just became too much of an issue. So we're always looking for him to have a plan that, gives him the minimal amount of medication with the best outcomes. But it becomes very difficult because he also has all of these other conditions. So when we look down and we see what other medications, I only listed a few here, but what other medications does he have in his treatment plan? He's got his EpiPen, he's got his antihistamines, like I said, in his nose spray. Oh, and I didn't list albuterol in his regular medications, but he has that. For his EOE, he does a liquid suspension of budesonide, a slurry that he has to drink daily. He's on omeprazole, and he's on multiple creams and controller medications topically for his eczema. So again, for a regular person, for myself, this would be a difficult regimen to follow. And now we're asking a family who already have many other issues going on in their family. They're homeless. They're trying to deal with a lot, to try and keep these regimens very clear. And that's where the help of having community health workers and home nursing coming into the home and trying to reconcile medications with them, give them some type of written, charts that they could chart the medications down and monitor them, was helpful. Let's see here. Here we can see, we're going to go on to the hospitalization history.
Also, Lisa,
Yes,
we
sorry.
are running close to our
Sure.
time. I just want to
Sure.
make sure that we have enough time to actually address
Yep.
your primary
So I
questions.
don't have to go through all this information. People can see in the screenshot
Yeah.
the significance and the risk for this child with all these multiple admissions. He was intubated. He's used BiPAP and high frequency nasal cannula. It's been quite a ride with him. The interesting part, as many people will say, we were very concerned about him through 2019, 2020, and then COVID hit, and we haven't really seen him much. I think we had one visit with him because the parents just won't bring him in. However, he's only had one visit to the pediatrician's office that was just recently that required oral steroids. So the picture definitely changed. He was homeschooled. He was sitting, in the environment with the parents all the time. So whether or not that, we really aren't seeing that it improved adherence to treatment, because when we review with the pharmacy, it looks like the same type of refills are happening. But just the change of environment. I will say the parents are smokers. I think I said that before, and we've worked really hard with them to, remove that from the environment for them. They also live in a homeless type shelter environment, which causes risk for that. Let's scroll down because we went already through all of the systems before. I think I listed everything. He also went to endocrine at some point because he was having adrenal suppression from all the steroids. So that was another risk factor for him. You can see the labs. I listed his labs here. The most recent one in 2021, his IgE is now 9,600. His eosinophil count is 480 cells per unit liter absolute count. You can see his lung function. His worst lung functions were back in like 2018. Most recent in 2020, they were, we were happy with his lung functions. Chest x-rays were never really anything of concern. We've done other testing to rule out other underlying or other disease processes. We've done workup for cystic fibrosis with sweat test and genotyping, and we've also had his genetics for hyper IgE syndrome, and all of those were negative. So his, you can see his labs. You can see how I listed all of his immunocap testing. You can see very, very high levels of multiple food allergens. Multiple, or everything's a class 6, so very high. And he does have he fluctuates with his weight, but he's been at a greater than 95% BMI now since 2019. He is on the shorter side. His height is only at 34%. So you can see how the steroids have affected him in that way. So I'll stop there by just saying he's now an 8-year-old male child with severe persistent asthma that at times is very poorly controlled. Over the last year, seems to have improved control. He has a mixed allergic and eosinophilic phenotype, type 2 asthma. He requires a multidisciplinary team approach addressing his asthma, as well as his comorbidities and psychosocial issues, as well as a complex medical treatment plan. What questions does anyone have? I mean, the questions our team would have is, does anybody have any great suggestions for us to look forward to? We would love to have smart therapy for him, but he's young still at this point. And one of the physicians actually looked into macrolide therapy at one point as a possibility for him. So right now things are on hold because he's doing okay. But in case our picture turns around again like it's been in the past, we may have to look at other therapies.
Thank you so much, Lisa.
Lisa, that was an amazing case. That's going to be hard to deconstruct in just a couple minutes. Maybe if we could talk a little bit about it, maybe next week.
Yeah, I think that's a great idea.
That would be great.
Yeah, but in general, maybe I'll just hit on a couple points that I thought were really interesting. One was the viral history. So there's a couple viruses that I find to be in particular interesting in the context of severe asthma. We think of rhinovirus and its linkage to future wheezing, and RSV as well too. Rhino in particular has been getting a lot of good, there's a lot of good studies showing the strong linkage between later on in life asthma with rhinovirus, and he's had it twice with Entro. And I think that many viral infections, I know you did an immune workup, which seemed really great. So I'm not, but it is intriguing. The other one is adenovirus.
Yeah.
Adenovirus can be linked with bronchiolitis obliterans.
Yes.
You can see it in select populations, specifically that in some of the Native American populations, specifically in the southwest of the US, and certain people of Mexican descent. So I don't know what his background is, but I do get very interested if someone has a history of adenovirus and has something that might be perceived as asthma, but not really asthma. But in your case, responds well to albuterol and steroids, at least he responds, because
Yes.
with BO, you don't usually see that great response. And then what superbly concerns me is that IgE level, and it makes sense you got concerned about.
It really concerned us too. That's why we had him in genetics.
Yeah, no, absolutely. I think I totally agree. Job syndrome should definitely be up there. I don't know if he has any other bony defects or any other concerns that you might be thinking of, but yeah, I assume it's all been worked up. You know, the eosinophil count, oddly enough, is not, I mean, it's high. But I don't know if that was acquired on steroids or off of steroids. That would have been
His last one was off steroids.
So that 480 was off.
That was recent. Yes, that was recent. He's had it higher. I think we had as high as 600 and change in the past that I remember when we were looking at biologics for him. Yeah, and we got approved for the Nucala with his eosinophil count.
Yeah, because I find as far as biologics for, you know, for Nucala, and we don't have much time here, it can work well with hypereosinophilic syndromes too. Right. And we can, and involves a huge workup unto itself and potentially CT scans and bronchoscopies, but we can get into that next week if time.
Okay, I look forward to it.
Thank you so much, Lisa. Thank you, Dr. Jassel. Yeah, I think that this is a great case for us to make a continuation for next week. And then Lisa, you can kind of review some other details if you want to that we weren't able to go over today. So I just want to say thank you again for presenting that case. We're really excited to see more discussion next week. Let's just jump right into our post-test questions for everyone, just so we can kind of get these under our belt. Question 1. Which of the following drugs is an IL-4 receptor alpha antagonist? Benralizimab, Mypolyzymab, Omalizumab, Depilomab, or Restlizumab? And question 2. Which of the following is not targeted by the currently approved biologic agents? IL-5, IL-17, IgE, or IL-4? All right, thank you all for your responses. I'm going to share these now. Okay, Dr. Jassel, how'd we do?
We did great. The group is generally correct. Dupexent is the IL-4 receptor alpha antagonist with downstream impacts also on IL-13. And which of the following is not targeted by the currently approved biologics? And you're correct. IL-17 is not one of our type 2 targets.
Excellent. Thanks so much, everyone. Thank you for staying a couple minutes over with us today. Can we get a big echo clap for Lisa? Thank you so much, Lisa. Really excited to continue your case next week when we talk about, oh gosh, I just lost it. Rachel, what are we talking about next week? Is it shared decision-making week? Oh, this is great. So next week is shared decision-making. So this is a great segue into that. Thanks again, everyone, for joining us. Hope you have a great week. We'll talk soon. Bye-bye.
Bye, everyone.